The story about FMT is changing, and with that, how we view protocols has to change as well. One dose doesn't tell the whole story because you're not only fixing one problem. This is like a multi-system, long-term issue.
Yes, it would be great if all of these diseases responded to a single treatment, but the reality and the evidence of the current research is pretty clear that that's not the case.
You're literally reteaching the body how to do the job it should be doing all over. So historically, when people think of FMT, they're thinking through the lens of C. diff. This is something that is most widely known and is most widely approved. And we know it as a single or two administrations. But with the expansion from colonoscopy to enema, now into capsules, as well as research really diving into chronic and more complex or immune-based or relapsing conditions, the story about FMT is changing. And with that, how we view protocols has to change as well. So I guess the best place to start here is from your point of view, Jason, like, why do you think protocols are even changing?
Yeah, the big change, as you pointed out, is that we're changing the product types. Most of the research to date has been around C. diff done rectally via colonoscopy or in some cases endoscopy. But the reason the protocols are beginning to change, and I think need to change much faster, is because we're starting to understand that FMT works great not only for C. diff, but other more chronic conditions, which we've talked a lot about here, everything from IBS to ulcerative colitis to neurological diseases, including Parkinson's. And the big distinction between C. diff and these other conditions that I mentioned is one is very acute, the other is much more chronic in most cases. In the case of C. diff, you have an individual, a single bacteria, that Clostridium bacteria, producing the C. diff toxins. And these patients who are getting the FMT are already doing what we call the pre-treatment with an antibiotic. So they've got this environment in their gut where they've already been hit with antibiotics. There's a single bacteria producing a single toxin. And by doing a single FMT treatment, we're getting a really positive outcome. I mean, we're seeing everything from as low as 74% sort of cure rate all the way up to 94% cure rate. However, now in historically, and this is, again, it's changing, but I think it needs to change much faster. Historically, we're seeing other studies using chronic disease treatment like the Parkinson's and dementias and autisms and others, where they're not treating it the same way. Because in these cases, these chronic disease cases, these patients have dysbiosis. It's totally a part of their system. It's been going on for many years versus a short blip in their, sort of microbial journey with C. diff. With these chronic diseases, this has been really entrenched. And so the way these trials are being designed is not having the outcome that it should in some cases because the protocol is flawed.
Yeah, and I think it's two different questions you're asking. In C. diff, you're asking, can we replace this one pathogenic bacteria so it has somebody to kind of regulate it? Versus how do we support not only engraftment to restore a dysbiotic gut, but ensure that it's resilient, ensure that it's helping with immune regulation, that it's reconnecting all these systems that have become in their own way dysbiotic because they're not connecting with the gut microbiome properly. And so, one dose doesn't tell the whole story because you're not only fixing one problem. This is like a multi-system, long-term issue. And so we have to start looking at it from a different standpoint. And we do see, and the original studies, there are cases where one dose has this huge outcome. So someone has, Alzheimer's and gets C. diff, gets treated for C. diff, sees huge improvements in their cognitive function. But the consistency is not the same there. That doesn't happen in every case. It's a good indicator that there's a connection there. That's a great first discovery. But then we get into, okay, so if we're going to treat 100 people like this, and only 5 of them show that magical change, okay, so there's probably different stories or how far gone things are or what systems have been impacted are different. But I think when we want to look at consistency and kind of really know what outcomes we're going to see, we're seeing across the research is it's not that one and done dose. It's how do we support this long term and really evaluate not only the changes in the gut, but also the changes in those other systems and see how long lasting this can be by supporting it longer so that we have long-term changes and reintegration of those systems.
Yeah, and you could imagine, right? Like a physician's treating a patient with C. diff and they also happen to have Parkinson's disease. They may have treated 10, 15, 20, 100 patients with C. diff who've also had Parkinson's or some neurological diseases, but never saw that dramatic change. When they see that dramatic change, there's noise, clearly there's a signal, and they published the case report. And that's great. I mean, we're advancing science, but the reality is when you expand it out across a whole bunch of patients, yes, there's going to be some patients that probably a single dose could work. But the reality when you're running a larger trial is that you're trying to get the strength of this, particular protocol and product or drug in this category for this very specific group. And I think it really brings to attention the study that was recently came out where they treated 114 adults for MDROs, so multi-drug resistant organisms, which are basically bugs that our typical antibiotics can't kill. They can be, you can have them in a sort of normal, healthy human, but it becomes a problem when the patient's immune system becomes compromised or they're hospitalized. Again, typically this is a problem in older adults, and C. diff was approved essentially because it helps to treat this drug-resistant organism. C. diff in some people. Well, they had 114 adult patients. They gave them a single a-FMT, and they didn't see a significant improvement in the rate of decolonization of these multi-drug resistant organisms. Now, what they did see is some of the benefits we often see with FMT is they did see more diversity. So that's great. And they saw more of the short chain fatty acid producing microbes or more short chain fatty acids. And then the big one, which everyone cares about and is very important, is safety. That was cool, but really not the outcome. And I think where it fell on its face is the fact that it was only done once. There wasn't continuous monitoring to see if a second, a third, a fourth dose should be suggested. And that's evidenced by another trial. It's called the premix trial, where that's exactly what they did. They had renal transplant patients who were colonized with MDROs, smaller study. And so, it's not necessarily apples to apples, but they gave them FMT. They retested for the MDRO. And if they were positive, they gave them a second FMT. And by taking that approach, only 2 FMTs, they saw 8 out of 9 patients who completed that second treatment compared to the controls be culture negative. And so just in that case, and that's a big part of what we're advocating for at Novel Biome as well as a part of our protocols, is don't just rely on a protocol that's defined for any one of these, typical symptoms or diseases. Like, monitor the patient over time and consider redosing. Like if we look at the research around ulcerative colitis, for example, you do a treatment and, hopefully you'll see a really great clinical response, a reduction in symptoms, but then keep monitoring them, whether that's just using validated treatment measures or, if possible, things like calprotectin, and are we seeing a signal where inflammatory markers for the gut are beginning to rise? Let's be proactive about trying to address this. And so I think we just need to rethink the way that we design protocols, in this context, trials, as well as how we monitor the patient over time.
Yeah. And I think really understanding the history of why this one and done concept really existed initially. And I think it's twofold. It's the C. diff case where it's an acute issue and you're really just hammering hard and basically helping to rebalance or provide competition within the gut to kind of push back the C. difficile bacteria that's overgrowing. But as well, even in those cases, 2 tends to be the magic number. But as well, it's what were the other options? When the initial concept of FMT became really large and when we saw it being used more wide scope, colonoscopy was, or some lower GI route was really the only option we had. And so the one and done makes more sense. Who's going to do daily colonoscopies for multiple days? That's not really, a feasible option. And so we have to put this in the new concept of capsules have only been around since 2019. And research and expansion is slow, unfortunately. But we're really seeing this trend of this expansion. And I think it's the types of questions we're answering and the tools we have to answer those questions have really changed.
Yes, totally agree. And I think that's again, I brought it up previously, but this very acute condition that can require that a very simple approach. And when I say simple, like a single colonoscopy, several capsules over several days is enough to change. But you got to understand, like when you're thinking about this as a sort of ecological system, one is just there's a short effect, little disturbance. The other is something that's really ingrained. And so the approach that we take in our protocols, and hey, if you're a physician, prescriber, a healthcare practitioner out there who wants to learn more about the protocols we put together, definitely reach out. But typically it would include a loading dose phase. Even prior to that, some sort of pre-treatment to clean things up, reduce the overgrowth. But then we go into a loading dose phase to like really inoculate the gut, overwhelm it with a seeded community of new microbes. And then once that's in place and we feel like we've overpowered their existing resistant microbiome, we go into a maintenance phase where they continue on. And again, it depends on the protocols and the research. That might look like for a month, that might be up to 4 months, that might be one capsule a day, it might be, 6 a week. So it really varies how you might design a protocol depending on the disease state that you're trying to treat. And then ultimately, while you're doing the maintenance phase, you're working to expand the diet and get them more prebiotics through the foods to support these new bugs to engraft. Meanwhile, avoiding antibiotics, avoiding microbial treatments that could kill these new transplanted bacteria. And then importantly, continuing to monitor the condition in the patient to ensure that if necessary, you can do a top up to ensure that you don't go into a full progression of this disease at a future date in the context of like some life event or stress or changes in a diet or something like that. Like, let's try to catch this early and be proactive and preventative.
Yeah, and I think the way I think that I changed my view on it, or maybe I read it somewhere. There's so much going on in the old noggin these days, but I think part of this is that when you're looking at a chronic condition that involves like multiple systems, as different systems come online, what the gut is going to require or what's going to be asked of it to build or supply is also going to change. So when we look at a condition which we know there's a dysbiotic gut, we know that the tight junctions in the gut are loose. We know that there's a miscommunication with the immune system or kind of malprogramming there. That inflammation is high. The gut brain connection seems to be somewhat disconnected. We're looking at even just like some brain fog or mood, those kind of things. Well, that's a ton of systems you're trying to fix here. And so, do you start at the beginning of, okay, with that loading dose, we're replenishing the population that needs to be there, giving it the instructions to actually function properly. And that kind of first step you're going to see is those tight junctions start to heal because it's able to do that. It has the system and the setup to kind of restore them. But then it becomes, okay, so now we have less inflammatory bacteria. We have a system that's not pushing stuff out into the wide body that should be staying within the gut. So inflammation changes. Well, that also is going to change the tone of the gut and the body. And then the immune system is going to start to re-regulate. Well, that's going to change the tone. So what's going to engraft and what populations are going to thrive changes as all of those things happen. The gut-brain connection becomes, the gut starts asking for more serotonin or relying on the gut to provide that more effectively. Then those populations are going to change. And your diet's going to expand, so you're going to be feeding these populations properly. And I think it's like part of this maintenance is like making these lifestyle changes, allowing each of these systems to heal so that it can require what the composition and diversity should look like in the body long lasting. We say like you're coming out of this with your own new little bucket of microbes that you're going to take with you everywhere you go. So it's, the success of FMT is becoming donor-like. The recipient plays a role in this, and your environment and your diet plays a role. So making all of these changes is huge. And so I think it's like a shift in terms of what we're doing in terms of an acute versus chronic. What are you tackling? And what does that look like from a how do you heal it? And then what does the body do when these systems actually work properly?
100%.
Yeah.
Yeah, makes a
So,
ton of sense. And I think a part of, on reflecting on this a little bit as well, is that a part of how we think about FMT and just how it's categorized generally as a drug is that we think it should have the same response as drugs do. And so most drugs, like, you're going to expect a response in days. And you would say drug didn't work if in days you're not seeing some notable change. Like even if we had to compare it to an antibiotic, right? In the context of C. diff, your choice is antibiotics or FMT or death, I guess. But in this case, like we can't face to face compare an antibiotic to an FMT, especially in these chronic diseases, because instead of in days, like most drugs, it can take weeks to establish a new community and then even months for it to stabilize and engraft and become your own version, just like you talked about, of the donor's version and your own versions, depending on your lifestyle and your diet and your sleep and all of the other factors that affect the success and outcomes with FMT. And so, the question isn't really like, did FMT work? It's really more about, did the protocol that you've designed and the patients following give the community of these new microbes enough time and enough support for them to be reinforced and grafted and effectively do their job? Like that study I talked about where they did the 2 doses, and there was the changes in dysbiosis, so more bugs and more short chain fatty acids. Like the benefits of more short chain fatty acids are going to take a while to be evidenced, right? So it's going to take some time. And that's why it's critical to monitor patients over time and really ensure that we're giving them the support they need to have appropriate engraftment of this new community. And that's a big part of course, what we're doing day to day as we educate and work with healthcare providers.
Yeah. And I think thinking of FMT as a process versus a singular, like changing event. But as
Yes.
well, like when you're thinking of more complex conditions or conditions that we really don't have a full grasp on, and I come to think of something like anxiety or depression and you're treating with an SSRI, you can't say an SSRI has failed until you've done it for 3 consecutive weeks. If you look at a biologic for ulcerative colitis, you're looking 3 to 6 weeks to even know if it could be working. And these are drugs that after those 6 weeks, you go, okay, we'll just continue to take them now. The thing with FMT that we're missing here, that maybe it's a whole shift in thinking about a medicine, is that it's doing this and then going forward and making your lifestyle choices, but you're not taking FMT forever. You may do top-ups, you may have to support it after an antibiotic or travel, or if you get food poisoning or something like that. Because the gut, I always like to think like it's still young. The new gut is still young. And so, you may need to support it again, but you're not taking it forever. And so that's the difference in this than the traditional pathway we've chosen with most synthetic based medications is like, if it works, then we know you will take this one going forward, versus if it doesn't work, we'll try another one. And this, waiting time to understand if it's working. I think that's the same kind of thought process you have to have. Like, is it working? What's our timeline in terms of when we should see the first initial shifts? And then the long-term thing is like, you may be treating for longer before you've decided that like, this is it. You're looking at 3 or 4 months. But after those 4 months, it's just continue with those lifestyle choices and going forward versus, waiting 3-6 weeks to know if a biologic or an SSRI is working and then going, and I'll take this forever, right? Like I think, I don't know, FMT gets held to this weird standard where they want it right away, and they don't put into context that it is a short treatment protocol for long-lasting results versus deciding if it works and then doing it forever. And I don't know, I have a hard time coming around with this. And I think the more we talk and kind of work through this, like how to build a protocol, and we've built a lot of them to kind of support at least the starting point for doctors in terms of like, how do we even tackle this? But even understanding like, what are we saying when we say a protocol? Because this is different than a traditional one. We're looking at how do we pre-treat? How do we prepare the person in the gut to do this? What does the FMT look like from a loading and a maintenance phase? You're actually changing your dosing from the beginning to the maintenance phase. And then what are we looking for from GI to more quality of life to more system-based measures? And we're building, the protocol is just built differently because we're really trying to rewire the body from within and getting all of these systems to work together versus putting, I don't want to use the word Band-Aid because that doesn't feel fair to some of these.
No, some of these drugs are definitely Band-Aids.
You're not covering up a symptom by like flooding the body with what it's missing. You're literally reteaching the body how to do the job it should be doing all along. And the longer the body hasn't been doing that, I don't know about you, but like if you take like 6 weeks out of the gym and then go back where you were 6 weeks ago, Like your body's like, we don't do that today.
Right.
We got to start back up. Let me give you. So like you have to really think about how the body works. And then what are you even, you're reteaching it, you're re-educating it to be the best version of itself that it may never have been. Some of these conditions start so young, the dysbiosis, and they could start even before the gut really began. And that's long lasting. So now you're trying to teach the body to do something it's never even done before. So you really have to appreciate how chronic, where these symptoms started, and then how do we rewire it?
Yes, yes, yes. Yeah, I think it's really thinking about this from like a bottom up approach versus a top down approach, right? You're really trying to give the body what it needs, deal with, what a lot of people would cause like root cause of the illness or disease. And that can be very hard to distinguish and even understand. But really thinking about you're supporting the body to do what it's naturally designed to do. You're not giving, like in many cases, drugs are just trying to force a very defined approach to how we think a disease works. And usually they're suppressing symptoms, not trying to change the sort of the essence of how this disease progressed and became a problem in the first place. So yeah, and this is a living thing versus a synthetic, right? And that's the big distinction here. It's like this is meant to become a part of the patient's microbiome and who they are in essence. I mean, we're more bacteria than we are human cells, shockingly. And so, yeah, this is really a critical piece, and it can be for some people. And I think we need to, as a community that's involved in medicine and science and trying to advance human healthcare, I think we need to be really appreciating the importance of designing protocols for the future based on our current understanding. We can't just keep this short C. diff model and apply it to everything else. I mean, yes, it would be great if all of these diseases responded to a single treatment, but the reality and the evidence of the current research is pretty clear that that's not the case. And so a longer protocol in most cases is justified. And to your point, I mean, maybe we need to get people more accustomed to the idea that they need to do this longer, like any of the other drugs on the market. But as it stands right now, that's not the case. And that's a great thing. If we can get away with a 2, 3, 4 month protocol for some very chronic disease, see significant improvements, and all they have to do is really make sure they're ensuring a good diet and appropriate sleep and activity and things. I mean, that's a pretty good trade-off. So yeah, it's an exciting time, and I hope that research going forward addresses this appropriately.
Yeah. And I think we're asking better questions. I think people are looking at this with a new frame. And we always joke about, we need to rebrand FMT, and I think there's fun ways to think about it when you're trying to really understand what this is doing. Put yourself in a context where you're in a room and there's the healthiest person you've ever seen. They eat really well. They create the right foods. They don't have any chronic diseases in their family. Would you not want that? Would you not go, wouldn't it be great to have if my body and your body could like talk and figure out what you're doing that mine isn't?
Right.
Kind of what we're doing. You're taking the instruction manual from a healthy person and putting it in, but you've got to reteach the body. And I don't know about anybody else, but when I learn a new skill, it takes a little time. And so really thinking about what's happening and like what discussions your non-talking body parts are having with each other, but like they are really starting. And in some cases, maybe just communicating effectively for the first time. It takes time. And I think we need to really think, and we've been saying this for a long time, but need to view diseases differently if they are acute versus if they are chronic. And I think looking at it from a preventative or a solution versus something that is mimicking what the body's supposed to do versus actually the body relearning, that I think really appreciates that shift from that one dosing or two dosing to these longer, more comprehensive protocols for chronic conditions.
Yeah, and I think just like double clicking on the protocol element here, right? Like we're not just doing FMT, we're supporting the patient globally to ensure that, yes, we're doing a transplant and we're putting in all these new microbes, but in the absence of other changes, we're probably going to end up back where we started, right? Like if the patient keeps going on antibiotics or they keep eating a very restrictive diet, like we're not going to be supporting these new microbes. And so, yes, it's a very defined treatment approach. However, the best outcome is going to come from a well-designed protocol that monitors the patient over time and gives their body the support they need to get this new community to engraft and do the appropriate job.
Yeah. And I feel like this in itself could be a series that we just took, but really, how do you go from, we want to ask a question to the final part of building out the protocol? What makes a good protocol? What are the questions you have to ask? What does supporting the microbiome look like over time? And so I think this part is really about getting you to understand how the field is shifting. And we're here. We're so excited about the fact that all of this is changing and people are asking these questions and really wanting to understand, how do we approach this well? How do we ensure the best outcomes? And that's what we're here to do. We're here to help you, talk with you through it, answer those questions, and figure out, what are you seeing and where does this fit and how do you best support, success while doing this. And so if you are a clinician and you're sitting here being like, ooh, that's really cool, I wish I knew more, you can reach out to us. We will be that know more. And we would love to have, we love having conversations, and we love, having one-on-one meetings and just kind of answering your questions and theorizing out what's changing, what's happening, what have we learned, what have you seen. And I think that's the best place to start when you're looking at a new field is, you'll know a little bit more than we do. In some cases, we'll know more than you. And then getting in a room together and really talking that out can help everybody learn. And I think set up how you're going to build a protocol and how you're going to approach this with the best success.
Yeah, we all learn more and ultimately patients win. So that's the goal here.
And this has been another exciting episode. And I would tell you what we're going to talk about next time, but it really depends on what cool thing we read that day, because we're following the science and we're following what questions we're getting to best support you in learning more as we learn and as we hear great stories from practitioners that we're working with. So catch us on the next one and reach out with any questions or something you'd like to hear us talk about, and we'll jump right on that topic.